I would imagine that for generations, preclinical medical students have been wondering if what they're learning is really going to be useful in the clinical years. I think the answer is usually yes, and probably almost always it's going to be more complicated and interwoven than you can appreciate right now. But just to reassure you, there's some value in what you're doing with this approach to acid base. Let's take a look. First, I'm going to show you where it wouldn't help you very much, but then we'll take a look at a case where it would be quite helpful. So let's start with a patient that I had recently. Just to orient you, this is the EPIC lab set, and I've removed dates in terms of HIPAA compliance. This is the time of day with the sun indicating a change of day. First day, the patient had emergency vascular surgeon, went to the ICU, and stayed there for several days, actually. Now, when it comes to clinical care, of course, everything is about the patient. And you need to know a little bit about the patient to best interpret essentially any study. So let's learn a little bit more here. This gentleman, according to NIH, should have been dead a long time ago. One of our cardiologists said to him, "There is nothing else I can do for you. You have outlived your disease." And a terrible disease it is. Rare dyslipidemia. His coronary artery is closed in his 40s. He has had stenting and bypass procedures. Just so you know, the term LEMA, or left anterior mammary artery, is still very commonly used in the cardiac surgery intensive care world. That's really the left internal thoracic artery, of course. The patient also developed aortic stenosis, and another bit of good luck, and was deemed unsuitable for surgery or interventional cardiology treatment of that stenosis. He had a nominate artery occlusion resulting in a stroke and had a stent placed for that. And he arrived on my doorstep for emergency revascularization of his lower extremity. It would be the only way to save the limb. This sounds like a terrible situation, and it is. But I will say the patient had a reasonable quality of life. After discussion with both myself and the vascular surgeon, he and his spouse appeared to understand the grave risk involved and wished to proceed. So here's the problem for the labs that we'll be looking at in this particular case. Up to this point, we have been presuming intact compensatory systems. And so we broke into our quadrants, which sadly in this case are not lined up the same way as the quadrants I use. But you get the picture that we've got a respiratory system and a renal system that can do what they're supposed to do to respond to primary issues of acid-base disturbance. This, of course, is a gross simplification, and we would need to be considering other aspects of everything from amino acid metabolism to the way the kidney actually works instead of considering a black box for now, and so on. But something beyond that we haven't talked about is the fact that this particular patient can't compensate, because during these labs he is unconscious, either under general anesthesia or heavy sedation with intentional pharmacologic paralysis, to let him recover and for us to manage the systems. And so when we talk about expected compensation, Well, we only have us to look at because we're doing it with a ventilator or with medications. And we actually can correct profound changes beyond what the body would typically do. So what do I mean by this? Let's just take an example. Believe he went up to the unit. Oh yeah, we can actually see. Here's the OR in green. And metabolic situation reasonably normal so far. And then in the unit, things start to deteriorate. And that's no reflection on the unit care. This is very predictable. What was going on in the OR is I was having to use very high ionotropic support and vasopressor support to keep this man alive and to keep blood going to his brain through that innominate stent. And I was incurring a cost in terms of perfusion that was paid for later by my intensivist colleagues upstairs. You may find it interesting to consider the oxygen debt incurred with the production of lactate from anaerobic metabolism. So once he got upstairs, what's going on? Well, now his pH is 7.349, just under normal. So he's got a metabolic acidosis on the basis of a decreased bicarb. By Winter's formula, we'd expect this to be 1.5 times 20 is 30, plus 6 to 10. And he falls in that range. So we are doing more or less what the body might do if you are awake and spontaneously breathing. But look over here. Now we've got a pH of 7.4, even though the bicarbonate has deteriorated further. By Winter's formula, we would expect a bicarb of 1.5 times 16.5. Let's call it about 25.5 for a quick calculation. PCO2 is in that range, but we have actually created what you could call a slightly alkalotic pH. This would not happen with the patient. There's no way of dealing with this with the methods that we've talked about. And also notice our lactate has gone from a little bit abnormal to high to pretty high as we move along the day. Here, bicarb exactly the same. Ventilation was decreased a little bit to allow the CO2 to come up, and now we're in a range where the pH is 7.27. So just emphasizing that we're the ones managing the ventilator, and we're the ones who have to think about it. And so we're really responsible for where this pH is and within the constraints of how much you can ventilate a patient safely and so on. Completely different issues. So applying Winter's formula in this case, not that helpful. We're going to rely instead upon thinking about our adequacy of oxygenation for this patient, what his lactate's doing, and whether we can clear it from his body and get him out of acidemic and acidotic trouble, and using anion gap to make sure that we're reasonably clear on what is happening. All right, let's take a different case. Here's a patient, again, thinking about the history, actually in pretty good shape, does have serious coronary artery disease, well-controlled diabetes. And so, again, in the OR, there's not a lot we can say about his disorder and compensation because we are in control of the ventilator. And in truth, if we wanted to give bicarb or tromethamine, then we would also affect the base in the patient as well. So these numbers don't mean a whole lot other than for us to be aware of where his pH is riding and how we should manage it. Here we see a lactate fairly early and coming up, and that's not so surprising because this patient would have been on cardiopulmonary bypass, which can't really duplicate the body's own perfusion. All right, so here we are managing with a ventilator, and somewhere around in here, the patient does get extubated. If that's an arterial PO2, it looks like it was a little bit challenging for him. I'm hopeful that's a venous PO2, but I can't be sure. And now let's take a look at this slightly low pH. So it's acidemic. We have a bicarbonate of 20. This seems to be our magic number from Winter's formula for this session. And we would expect a PCO2 of 30 plus 6 to 10. So dead in there. So he is doing exactly what we would expect him to do. It's a metabolic acidemia because bicarb is down. It's an adequate respiratory compensation, even though it's within normal range for PCO2. And it's an acidemia because this is below 7.35. Now, a couple hours later, what's going on? Well, the bicarb is now up to 22.8. But it doesn't really matter because it matters a lot for the patient. It doesn't really matter for our calculations because now we enter a stretch where all the pHs are within normal range. So we don't have an acidemia or alkalemia. We have normal pH. A couple of things to note here. Notice this very high lactate. Patient's still on a ventilator and has a low pH. Resolving lactate is associated with an improving pH. Also, this patient has a low albumin, and since a gram per deciliter of albumin contributes approximately 3 anion equivalents to the anion gap, the expected anion gap should be adjusted down. So this really is not abnormal for his hypoalbuminemia. Just a few observations from real patients. So, is it helpful, the information we're learning now? Absolutely, both in terms of concepts, but also in terms of the actual tools. Is much of it a gross simplification that you'll have to build on for the more complex circumstances you'll see in our sick patients? Absolutely.